So this is a trial study we currently have ongoing. This is a very promising and novel immunotherapy that we are studying in the frontline setting. So ICT01 is a first-in-class immunotherapy which activates γ9δ2 subtype of cells. So the mechanism of action is very interesting and it's very different from other immunotherapies which we have evaluated. Previous immunotherapies, particularly PD-1, L1, CTLA-4, and CD47 agents are essentially checkpoint inhibitors, either on alpha beta T cells or macrophages. And then some of the other antibodies we have evaluated are IgG1 antibodies, like CD70 and CD123, CD33, which cause ADCC, ADCP. But what this antibody does, it binds to BTN3A, to the extracellular domain, and changes the conformation of BTN3A to an active conformation. So essentially, it bypasses the physiological mode of activation, which requires a phosphoantigen and leads to activation of γ9δ2 T cells. So you can imagine that cancer cells can evade immune recognition by not producing phosphoantigens. So this bypasses that physiologic mechanism. And in this study, this drug has already been evaluated in a single-agent phase 1 salvage heme malignancy study. And in this study, we evaluated this in combination with standard doses of aza-ven in frontline population in older unfit patients with AML. And the aza-ven administration was per USPI standard of care, and the immunotherapy infusion was once every cycle. So the immunotherapy was infused first, followed by aza-ven. And the rationale for combining these are multiple. One is that aza-ven will help to reduce the leukemia burden and improve the effector to target ratio in favor of the immune cells. And then ICT01, any immunotherapy, as multiple investigators have shown, these immunotherapies, they synergize with BCL2 inhibition, because BCL2 inhibition reduces the apoptotic threshold of the leukemia cells, and then immune cells have better capacity to now kill the leukemia cells. And through all these three medicines together, we're targeting the intrinsic and the extrinsic apoptotic cascades. Apart from that, the novelty of this approach is that γ9δ2 T cells, having both innate and adaptive immune capacities, can directly kill AML cells, which IMCHEC has shown in their Science Translational Medicine paper. But in addition to that, the cytokine secreted also leads to activation of immune bystanders, NK cells, CD4, CD8 T cells, which we have shown in some data presented at ASCO and others. So that's the rationale. And the data that we presented at SOHO, we presented the data of total 45 patients, and the median follow-up was around 9-10 months. And what we showed in this study, we evaluated two dose levels, a low dose and a high dose, to study the clinical impact and safety of sustained versus intermittent activation of γ9δ2 T cells, and to also satisfy Project Optimus expectations. And we found that both doses were safe, but maybe the higher dose with sustained drug level was leading to sustained activation of γ9δ2 T cells, leading to less probability of these cells to recover and potentially causing some activation-induced cell death, which we saw in our PK/PD data and in terms of recovery of the γ9δ2 T cells. This, along with all the emergent data from their solid tumor study, we decided that we're going to proceed with the low dose for our future trial. So that's something we established in this. And in terms of safety, it appeared that the safety of the triplet is very similar to aza-ven alone. Neutropenic fever rate was around 51% compared to 42% with aza-ven alone. And other side effects, rates of neutropenia, sepsis, fatigue were very similar. So in terms of safety, no specific safety concerns. One patient, the very first patient treated on the protocol, had a transient grade 3 CRS. But since then, we have incorporated steroid pre-medications, which has abrogated any further CRS in these patients. The efficacy signal was very encouraging. So although this is sort of small sample size, early follow-up, so in the efficacy population, we had around 40 patients, but we saw significant improvement in CR rates. In the ICT low-dose cohort, we found full CR rates with complete count recovery of 74%, and composite CR rates, so CR, CRh, CRi, of 96%. And in the ICT low dose, ICT high dose group, at the higher dose of ICT01, we found that the CR rate was 44% and composite CR rate was 69%. Having said that, this population was very similar to VLEA, median age 75 years, 30% secondary AML, around 30-40% of TP53 across the two cohorts. The ICT high group definitely had around 50% TP53 mutated patients, which led to the lower response rate, but you can think of the ICT high group as an internal control. And in terms of overall survival, the data is still very early. Median follow-up is only 8-9 months. But the 9-month overall survival for the ICT1 low group was around 80%. And the 9-month survival for the ICT1 high group was around 56%. So I think overall the take-home message was that the combination is safe, no specific new safety signals, no immune-related adverse events per se, and the CR rates are very promising. Early follow-up, overall survival data still maturing, and we're going to continue to follow these patients to see how the overall survival data pans out. So in summary, very promising novel immunotherapy showing early encouraging responses, and we will present some of the long-term follow-up in upcoming meetings.